Classic Hodgkin lymphoma that progresses or recurs after autologous stem cell transplant has been an incurable disease. And treatments are highly palliative to keep the disease at bay, but we can't get rid of it for good. In this disease, in the previous era before novel agents, overall survival was described as up to 2 to 3 years in various literature. With introduction of checkpoint inhibitors and Brentuximab vedotin in this space, in classic Hodgkin lymphoma that recurs after stem cell transplant failure, we have seen durable responses, durable remissions in clinical trials. So with this study, we sought to assess whether introduction of these novel agents has improved overall survival. There are some reports already out there, but those studies have a low number of patients who were treated with novel agent, understandably, because they were just introduced now. So here we have about 300 patients data collected from 14 institutions in the United States. All had classic Hodgkin lymphoma that progressed after autologous stem cell transplant. And we reported the median overall survival of 9.5 years, which compares very favorably to prior studies before novel agents. In this study, majority of patients received novel agents at some point, either Nivolumab or Brentuximab vedotin. And more patients received Brentuximab vedotin because Nivolumab or checkpoint inhibitors, Nivo or Pembro, they are still recently approved in this space. We saw that increasing age is significantly associated with worse overall survival, but still patients who are more than 40 years old, they do significantly worse compared to younger patients. But in that population also we saw promising overall survival. Median overall survival is up to 50% at 5 years. So 50% of those patients were alive at 5 years, which is pretty remarkable. Patients who have disease relapse within 6 months of their transplant also do significantly worse than patients who relapse later on. These two are these two predictors, like increasing age and decreasing time to relapse. They were known factors predicting worse prognosis in the pre-novel agent era as well, and that stay as a worst prognostic factors in the era of novel agent. So that underscores a need to improve outcomes in that population, like patients who relapse within 6 months of transplant and patients who are older than 40 years. We also saw that checkpoint inhibitors first at relapse, like first treatment for post-BMT relapse, was significantly associated with improved overall survival. BV or chemo was not associated with improved overall survival. If you get BV first or chemo first after autologous stem cell transplant, you might do worse than if you get checkpoint inhibitor first after autologous stem cell transplant. So that sort of underscores higher efficacy of checkpoint inhibitors in inducing response and prolonging remissions. We also saw that introduction of or bridging with allogenic stem cell transplant was not significantly associated with overall survival. So likelihood of dying from classic Hodgkin lymphoma or likelihood of dying in general does not change if patients were bridged to allo transplant or they were not. So that's a very important piece of information, because in this population there have been attempts to characterize what's the optimal strategy in terms of whether they should be bridged to allo transplant or they should not be bridged to allo transplant. And I think our data is retrospective, but sort of shed some light because it's a pretty large population in this disease.